Hello, 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 everyone, and welcome to another What's Up Doc Tuesday, where we have amazing vascular specialists and podiatrists from across the globe who join us just about every Tuesday to answer your burning questions about peripheral artery disease. Now, if you've never heard of peripheral artery disease is basically just blockages or narrowing in your arteries below your knees. It can happen in your arms, but mainly we see peripheral artery disease presenting in the knees. I mean in the legs. I am going to go ahead and put some folks over here on mute, just making sure we do have a live studio audience as we go into this particular broadcast. And so you never know who's going to pop in and pop out during our live broadcast. But if you do have questions for the doctors that we do have in today's show that I'm going to be introducing to you in just a moment, make sure that you do, if you're in our live studio audience, go ahead and raise your hand or put your questions in chat and we'll call on you. And if you are in YouTube, we have our amazing YouTube producer, Joshua, who is manning those comments. So make sure you do put your questions and any insider comments that you'd like us to share here in the broadcast with our doctors. Just go ahead and put them in comments and we'll get to them. But I'd love to introduce you to our doctors today. We have an interventional, I should say a vascular interventional radiologist, Dr. Mark Lessne, and we also have Dr. David Ellenbogen. He is a podiatrist also in North Carolina is where they're both from. We'd like to welcome you. Should we say hello to Dr. Lessne first? Hi, Dr. Lessne.
Hello, hello. Thanks for having me.
Of course. Before we get to Dr. Ellenbogen, why don't you just introduce yourself, your practice, and what your specialty is?
Yeah. So I am a vascular interventional radiologist. I practice in Charlotte, North Carolina. I am a predominantly vascular focus, so both peripheral artery disease, vein disease, patients with end-stage renal disease, liver interventions with portal veins. And so all things vascular is sort of my main specialty.
Fantastic. And now I'd like to introduce everyone to Dr. David Ellenbogen, a podiatrist in North Carolina, works very closely with Dr. Lessne. Welcome, Dr. Ellenbogen. Thank you. It's so great to meet you. You and I have never had a chance to cross paths until today.
Hi there. Yes, thank you for having me. I've been following you for a while on LinkedIn, and kudos
Uh-oh.
to your very, very highly followed podcast. And thank you for having me again. We're both here in Charlotte, North Carolina. It's a great area to practice medicine, and Dr. Lessne and I work closely together. I do pretty much exclusively diabetic foot and ankle surgery and deal with patients with significant peripheral vascular disease complications, whether it's coupled with diabetes or not. So this is something that, myself and Dr. Lessne both see on a daily basis. And I wish there were more opportunities to take advantage of to educate the public and answer questions like we're about to. So thank you so much for having us.
Yes, this should be a pretty exciting hour. We have, quite a few folks that have written in ahead of time. Couldn't wait to actually ask you some burning questions. And we have some folks here in our live studio audience as well who are gonna. I already know ahead of time. They don't even need to raise their hands. I know they have questions for you as well. But before we get started with these questions about peripheral artery disease, we do want to take a moment to acknowledge, the hurricanes that have just left so much devastation in their wake, across, the Eastern Seaboard. And in particularly, we are hearing so much about North Carolina. So would you mind each just taking a moment to share, with everyone, what is the situation there? And especially, what are you experiencing with your patients and your practice?
Yeah, I think where we are, we're fairly lucky that we were spared from the most of the damage from Helene. Western North Carolina, the mountains, Asheville, surrounding area, they just got devastated. And so our heart goes out to them. I've already seen patients that actually had scheduled appointments or procedures or surgeries in Asheville that actually had to come here emergently or urgently. And we're trying to get them in quickly and make sure they're taken care of. A little bit of audibles being called every once in a while. Not exactly what they needed in Asheville, but something we can do quickly to get them in. So, I know the response to them is overwhelming, both on the formal level and also the sort of community level. So our heart goes out to them and wish everyone well.
And know that we at the Global PAD Association, if you give us a call or they give us a call, we're happy to help with transportation. We're happy to
Mm,
help with co-pays if they need. We're happy to help with some healthy food for some of those patients. So make
that's
sure to keep us
amazing.
in the loop if there's anything that you or those patients need, especially when they're coming such a long way to come see you from Asheville. We're here for however we can help. Okay.
Yeah, that's awesome.
And Dr. Ellenbogen, how about you?
Yeah, no, I have to say the most impressive thing to me so far has been the coalition of people and chapels, churches, temples,
Yeah.
schools, everyone sort of banding together to be able to get resources out to the western part of the state. And it's been very impressive and just kind of it puts your heart at ease a little bit to know that people do are able to rise to the occasion and think about others and help others. In terms of clinically, much of what Dr. Lessne said is very accurate. We're also seeing, unfortunately, there's a lot of manufacturers. Baxter is probably the biggest
Yeah.
one, whose plants and warehouses were affected and impacted negatively by the storm. And so it limits our ability to get resources for our patients here. And so
Yeah.
the hospitals have been on top of that, and they've done great things to get the word out and try to pivot and make sure that we're, adapting and doing what we can to use the resources wisely and not kind of overuse and be able to conserve while we're dealing with this.
Yeah, talk a little bit more about that because I took a tour of the San Francisco Bay Area today and visited four vascular surgeons and an interventional cardiologist and an interventional radiologist. And the one thing that kept being said over and over again is the concern over a shortage in saline and the expected cancellation of quite a few procedures over the next few weeks that are considered elective. Can each of you talk about that because that is concerning? And is that due to Hurricane Helene and the damage there and such to those manufacturing facilities?
Yeah, absolutely. I think it is obviously directly related. We have a lot of unfortunately sick patients who are dehydrated inpatients, or they're kept what we call NPO. They're not allowed to eat or drink before surgery if they need an important procedure to be done. And so it's easy to become dehydrated during that period. And so we
Yeah.
like to support these patients with fluids. And those fluids, like you said, saline and lactated ringers and other sorts of fluids that we tend to give intravenously are in limited supply right now. And so that does force us to stratify patients and procedures and, be able to uh, avoid having to put anyone at undue risk. So it has impacted us, and it sounds like, not just the Eastern Seaboard, but nationally. Baxter is one of the largest manufacturers out there of those products, and so
Yeah.
it's definitely it's definitely in our face, no matter what your specialty is. We're seeing it, and the patients, are being impacted by it.
I'll tell
Yeah.
you the silver lining and glass half full is that we just went through a global pandemic. And I think that sort of trained us to not take things for granted. And so
Yeah.
I've been very impressed. My practice and the hospital already has sent out an email stratifying, here's how we're going to manage this and here's how we're going to deal with this. And so it seems like everyone is fairly on the ball with this IV shortage. And I do think we learned a lot of lessons from the COVID pandemic on how to deal with things that we never thought in our career we'd have to deal with.
Yeah,
And
the
I
emergency
think
preparedness teams
Yeah.
are second to none here, and they've obviously got a ton of experience now, especially in the last few years.
Yeah.
it's more important than ever for these patients with peripheral artery disease to really focus on their conservative treatment and take their
Mhm.
walking programs really seriously right now. Because, I mean, if you're an intermittent claudicant, if you're experiencing lifestyle limiting claudication, for those folks, unless you have a wound that will not heal, and you have rest pain that wakes you up at night, you are not going to be considered a priority, and you're going to have to resolve some of those issues on your own. You're going to have to be diligent about taking the medications as prescribed. You're going to have to be diligent and push through that pain and grow those collateral vessels. I think that's really important now more than ever, because these hospitals and office-based labs just won't have the resources in the meantime until we get through this. Is that correct, Dr. Lessne?
Yeah, I mean, I think there's a lot of correct things you just said. But just do keep in mind that care about all our patients, and we are triaging as best we can, just like during the pandemic. Just please do keep that in mind and be patient with your local provider, your local hospital, and know that everyone really is trying as hard as they can to take care of you.
Yeah. We do have some questions coming in
Sure.
already. We have Kim. Kim, go ahead, unmute and ask the doctors your question.
Hi there. I was just wondering, is it important to pay attention to heel to toe depths when you're a pad patient?
That's an excellent question. And I don't think that heel to toe depth is a very important thing for biomechanics of the foot and ankle and for everyone really. And what it will affect most is sort of the tension on your Achilles tendon, which is that big, Achilles, big tendon behind your ankle that really powers your foot and gives you that mechanical advantage when you're walking. And so people with tighter Achilles tendons, especially diabetics, can suffer from tight Achilles and can suffer from Achilles tendonitis with walking a lot or just starting an exercise program. Peripheral vascular disease doesn't necessarily make you prone to that, but it can be a little bit tougher to heal something, HEAL, heal, something if there is some inflammation that develops because you have sort of a zero drop or, sort of no heel compared to where the toe sits in the shoe. So a heel to toe drop basically is how much higher is the heel to the toe and how does your foot sit? And so when you have a 7, 8, 9, 10, 11 millimeter drop from your heel to your toe, your foot's allowed to sort of sit in almost a pseudo high heel position, a very low and relaxed high heel position. And that takes the tension off of your Achilles a little bit. And for some people, just enough to not cause any pain and inflammation. But so, if you're someone who kind of suffers from plantar fasciitis or heel pain a lot, or ankle pain where it's behind the ankle and your Achilles tendon, if that's something you're prone to, then it's probably best to try to find yourself a shoe with a good heel to toe drop of at least 8, 9, 10, 11 millimeters to hopefully avoid any sort of complication that you might have trouble getting through. Because the more you walk, obviously, with peripheral vascular disease, the better off you're going to be, and the more collateral vessels you can grow and hopefully improve your condition.
There's nothing better than having a podiatrist actually talk about those collateral vessels. This is a
All right.
first for me, so I'm very impressed.
I have
Very
a lot
impressed.
of colleagues who are vascular surgeons, interventional radiologists, interventional cardiologists, and so it's been drilled into my head over the last 20 or so years. And I feel very fortunate to have such a close relationship with all of them because they all make me look very good. Because when I work on wounds of the lower extremity without blood flow, I just can't do what I do.
It's funny. When I talk to my patients, I have the exact same line in reverse. And I say, I can get you all the blood flow in the world. But if you don't have a good wound care doctor, if you don't have a good podiatrist, if you're smoking, if your sugars are out of control, we got an uphill battle. And so this is a team sport.
Amen.
I love that. We always make sure that when a person goes to, gets diagnosed with PAD, we always say you need, 2 or 3 people typically. You need your vascular specialist, you need your podiatrist, you need your diabetologist or endocrinologist. And that's going to be a very key team. And then if your insurance company covers it, then you need also, I think dietitian is important. And then on top of that, if you can get a referral to physical therapy, there you go. That's
Amen.
key. So that's kind of that
Great.
circle of heaven for PAD patients, I
Yeah,
think.
right.
We do have a question that came in from Joanna a little earlier, Dr. Lessne. She'd like to more info on the success rate of stenting the superior mesenteric artery in the gut. She had one vascular surgeon that told her it was too risky to do it. And then now she's found another vascular surgeon at a large university that says, what do you mean? It's easy. I do them all the time. So she has a procedure next week and she wants her fears
Yeah.
eased. Can you talk about the procedure?
I can. So just to give some context, everything we've talked about so far is peripheral artery disease in the legs, which is narrowing or blockage in the arteries, as Kim said very well. That restricts flow. And the analogy I always give is if you're on a 4-lane highway, traffic's moving. If all of a sudden that highway becomes 3 lanes, 2 lanes, 1 lane, 0 lane, traffic builds up, right? And you don't get to where you're going. Well, that's the same way with your arteries. If your blood flow is not going through your legs because your highway is closed or narrowed, you're going to have a hard time getting blood flow to where it needs to go. So that's in the legs. Every other part of the body is exactly like that. The brain, the heart, the gut. The superior mesenteric artery is one of the 3 major arteries that supply blood flow to the gut, the bowel, the colon, the small bowel, things like that. And the analogy is exactly the same, that if you narrow that blood flow, you're going to have a hard time getting blood there. And patients can be symptomatic. And most of the symptoms that we think about with this is you have a large meal or a meal, and all of a sudden you get really bad cramping abdominal pain. Because again, your gut says, oh, I'm eating, I better get more blood flow. And the highway says, nope, I can't get you more blood flow. And so you start cramping just like your legs would, right? If you were walking. So it's the same phenomenon. Now, a lot of patients actually get such bad pain that they actually stop eating. And so weight loss is very common. You get something called food phobia, where they actually fear eating because it's so painful. So these are the things we think about. And that whole constellation of symptoms, when it happens over a long period of time, is called chronic mesenteric ischemia. Okay. Now, there are a lot of different reasons for belly pain. So don't think just because you have belly pain, you've got mesenteric ischemia. There's tons of other reasons. But if you are someone who's got restricted blood flow in your arteries to your bowel, and you have those symptoms, and you've been evaluated by someone who deals with this disease, a vascular specialist, one of the main ways we treat it is to put a stent in one of those arteries, specifically the superior mesenteric artery, to again turn your 1 lane highway to a 4-lane highway. You do need to talk to someone who knows what they're doing. You do need to make sure you're a right candidate. There are a lot of patients who have SMA disease who do not need a stent. But if you are one of those patients who do, a stent is usually our first-line therapy.
And are there a lot of risks when it comes to treating the SMA?
So the risks are always going to be dependent on you, the patient, on the local expertise of the person doing the procedure. And usually that's sort of the combination. So, what are the main risks? Obviously, as I tell my patients, the main risk is every time you go in a blood vessel, there's always a risk of injury to that blood vessel, injury to whatever organ you're treating.
Right.
But in general, we do SMA stenting pretty safely. Obviously, your risk profile may vary depending on what kind of disease you have, what kind of other diseases you have, how bad your blockage is. But it's generally a safe procedure done in the appropriate setting by the appropriate person.
Is that a vessel in which you can do a little roto-rooting in there as well? Or is that something that is strictly, you send in IVUS, the intravascular ultrasound, you check it out, and then you try to get the right size balloon in there and then the right size stent?
Yeah, the latter. We tend not to do any atherectomy or anything like
I would
that,
think that would be a little
roto-rooter.
dangerous.
Yeah, and you don't
Yeah.
want to shower things to the bowel. So generally, what we do is we go in, we angioplasty or stented primarily and call it a day.
Yeah, no, probably a good call.
Yeah, right.
Um, one of the things that I always tell patients who have been diagnosed with PAD is at some point, once we get your PAD stable, then I always say you need to go ahead and talk to your doctor about just doing a double check to make sure all of the other arteries in your body, check your heart, check your abdomen, and just make sure everything is just flowing the way it should and that you don't have additional buildup there that could put you at sudden risk of something else that could be life-threatening. What is your viewpoint and advice for these patients with PAD? What would you tell them to get tested for if they've been diagnosed with PAD?
Yeah, so that's the beauty of that SMA question, by the way, because even though we're not talking about the legs, all vascular disease is related. And so if you have PAD, that means you are at a much higher risk of having coronary artery disease in your heart and
Mhm.
cerebrovascular disease in your brain. And so there are a lot of patients who see me who have PAD, which just means they have some narrowing or blockage in their arteries, but they don't need treatment for their legs because they're not symptomatic or they're not symptomatic enough. However, they do need treatment to reduce their risk. And so what I tell patients with PAD is you need to talk to your primary care doctor because once you have PAD, that is a cardiovascular risk factor equivalent. What does that mean? That means even if you've never been diagnosed with heart disease, you've never had a heart attack, you've never had a stroke, if you have peripheral artery disease, it's as if you did. Okay? It's as if you did. So the medication we treat you with, the way we approach you to make sure your risks of having a heart attack or stroke are lowered are exactly the same as someone who does have that more severe heart or brain disease. And so what I say is if you're diagnosed with PAD, you need to make a beeline to your primary care provider and say, hey, I've been diagnosed with PAD. What does that mean for me? And they should do things like cholesterol management, hypertension management, blood pressure management, and they should walk you through all the cardiovascular risk reduction strategies. And that's really important because we can save legs, but just as important is we can save lives, right? And I tell my patients, you're not going to die of an amputation, you're going to die of a heart attack or stroke. And my job is to stop the amputation, but my job is just as important to stop the heart attack and stroke. We got to keep our eye on the prize.
Yeah, definitely. Thank you, Dr. Lessne. Okay, we're building up in questions here. I could actually ask you a million questions all day long and just keep you here all night, but I want to respect our audience. I want to go to Heinz and then we'll take Alan afterwards and we'll get to some of those questions that are lining up in chat as well. And remember, if you are watching on YouTube, go ahead. We have our YouTube producer, Josh, who is right there and he's ready to grab your questions as well. Go ahead, Heinz.
Good evening, Dr. Ellenbogen. Along with pad in one of my legs, I also recently got diagnosed by a podiatrist with plantar fasciitis. Quite painful, but it's being treated. In your experiences, how long does that last, or could that last? And what I read someplace that I should avoid a treadmill. Now I go see her on Thursday again, and I'm going to ask her the same question. But she's treating it, and I'm thinking that she's going to put something on the arch there. She gave me a temporary bandage that's really helping with my walking. So I'm thinking she's going to give me something more permanent after Thursday. But curiosity question: what's your impression on how long it could last?
Yeah, so nice to meet you. Thank you for the question. I appreciate it. Sorry to hear you're dealing with that. And you are sort of in a tough spot between, a kind of a double-edged sword with PAD. We're going to encourage you to walk and try to improve that condition. But unfortunately, with plantar fasciitis, walking can be a little bit traumatic, especially on a treadmill and even, more so on concrete for, the structures that cause plantar fasciitis, that plantar fascial ligament that attaches to the bottom of your heel bone. And so plantar fasciitis is one of the most common musculoskeletal issues that people deal with around the world every day. And it's usually not too tough to treat, but it takes a lot of patience on the people who are suffering from it on their part, because it doesn't get better overnight. It really doesn't. Unfortunately, there is no quick fix. There's no magic pill, but it's a lot of lifestyle sort of augmentation and changes where, you have to kind of avoid walking barefoot a bunch, and you have to give the foot a little bit more cushioning and support. A lot of people don't realize, but a firmer insert or arch support is better because it will help to support your foot and relieve the tension on that ligament, the plantar fascia, so that it can heal. The sort of gel or cushion or memory foam type of inserts, they just don't give you as much support. They'll give you some shock absorption benefit, but the foot is just a very complex structure and the architecture of the foot really likes that firm support and likes a lot of arch support. So that's why we tell people to avoid flip-flops and walking barefoot. And so there's lots of great brands of shoes and sandals out there now even that incorporate really good arch support into their form, and the function really it speaks for itself because people do tend to feel better a lot more quickly. I think that you probably are looking at somewhere in a 2 to 6 month time frame in terms of depending on how aggressive your podiatrist is in treating it, and how aggressive you want to be in that approach as well, and then how much and how steadily you can modify your lifestyle to accommodate that condition. But usually it's more than a couple of weeks to really get yourself significantly better.
Doctor, I love my
Thank you.
UFOs.
Yeah, they're great. I have a pair myself. I really like them. And, I try to recommend brands, but a lot of brands change their offerings so quickly. It's just there's too many to keep up with. So I try to instruct people to sort of pick up a shoe or pick up a sandal. And if you can fold it into a pretzel, it's probably not going to give your foot the support it needs. And if you can, sort of mash it really, and there's a lot of foam to it, but not a lot of sort of firm rubber to it, then it's probably not going to give you, the shock absorption and support that you need either. So those are a couple of easy things to do when you're shopping for shoes that are going to help your condition.
So why do some doctors wear Crocs, but then they tell the patients not to wear Crocs?
I haven't had a pair of Crocs in a long time. Crocs are really good for people who, can just wear them in a limited amount. But I find, and I'm not, I don't want to speak negatively about Crocs because I do think they serve a great function. But unfortunately, most of their styles are just not supportive enough for people who are suffering from foot conditions. If your foot is fine, it's not bothering you, and you don't have any complaints, be my guest. Go ahead and wear whatever you'd like.
It's interesting. When I was in Europe, I went into quite a few hospitals and their cath labs, and you would go into the changing room and you'd have to wear a pair of Crocs. So they'd have Crocs waiting for everyone in the entire OR. Yeah, everyone wore Crocs, which I thought was quite interesting because I didn't see that actually here in the States, but overseas, I can't tell you how many hospitals where, not only do you get your scrubs out of a vending machine, in which if you don't speak the language, you're not sure what you're ordering, but then you got to get your Crocs on.
Certainly sounds like a sanitary and a hygienic approach.
Yep, definitely. Alan, go ahead, unmute and ask your question of Dr. Lessne and Dr. Ellenbogen.
Hi, doctors. I'm not certain who's the best one to answer this question, but I was diagnosed with PAD 8 months ago, and a couple of months ago, I started feeling what I believe is peripheral neuropathy in my feet. And a couple of weeks ago, I started to feel a wound on the top of my foot. It feels like I've cut myself or scratched myself, but there's nothing visible. You can't see anything. I don't know, should I be asking to see a podiatrist about that wound?
So I think your question gets at a very challenging part of treating PAD, which is there are a lot of patients, actually, as the speaker who just asked the last question, there's a lot of overlapping diseases. So we have patients who have peripheral artery disease, who also have plantar fasciitis, who also have peripheral neuropathy. And so it can be hard to sort out. And so I think you're doing the right thing in terms of inspecting your feet. If you have PAD, if you're a diabetic, if you have diabetes, you need to be looking at your feet. Or if you can't look at your feet, have someone look at your feet. And the answer to your question is, should you see a podiatrist? I think the answer is yes. If you have any question, I don't think I tell my patients, I get called all the time and patients say, well, I didn't want to bother you because I was embarrassed if it was nothing. Okay. Yeah. And I tell patients this, I am much more embarrassed if you don't talk to me and it turns out to be something. You are never wasting my time. And I think most good providers feel that way. And so if you're worried about something in your feet, you should have a very low threshold to say, you know what, let me get it checked out. And worst case scenario, you go there and they say, no, it's nothing, you're fine. Awesome.
Yeah.
But I have a low threshold to say, you know what, check it out.
Okay.
Yeah, I'd agree 100% with Dr. Lessne. You know, that's one of the last things that that I tell most patients before I walk out of the room. And a lot of my patients have undergone surgery for some sort of complication in the lower extremity and the foot. And so they already might have a wound or have had an experience with a wound. But I always tell them, you know, whether or not we're still working on getting it healed or it has healed, if there's anything that you notice that smells out of the ordinary, feels out of the ordinary, looks out of the ordinary, just call me and come in and let me take a peek. Because what could it hurt for me to look at it for 2 minutes and you to just make a quick run over here that could literally save you from a hospitalization, an amputation, God forbid, you know, sepsis, you know, and worse. So yeah, I'd have to agree with Dr. Lessne on that. It's always better to get it checked out. And especially, you know, if it's on the top of the foot, peripheral vascular disease can change your body and your skin's ability to heal and and recover from just the daily micro traumas that occur from walking, from a shoe rubbing, from, you know, just a minor bump against the counter in the bathroom. And so, you know, when you can't recover and heal as well from those little things, which our bodies kind of do constantly, your skin's delicate now, and it will be for the rest of your life. And so you just have to, besides moisturizing, which I know there's a comment here and a question about, which is, you know, just a very astute point. It's always great to inspect your feet daily and your lower legs, and try to moisturize, especially within a few minutes of after bathing or getting out of the shower. And then, you know, just kind of do a daily inspection. And if something doesn't look, if something's new or doesn't look normal to you, then yeah, certainly get it checked out. No question about it.
Okay. Thank you. Thank you very much.
And we should address the question in regards to the moisturizing of the feet. When I was told never, ever, ever between the toes.
Correct. I'd have to agree with you there. I preach the same advice. I think that, you know, in between the toes, unfortunately, with age, with diabetes, and sometimes just with genetics, we can get our toes can become a little stiff. They can also become a little contracted. You can have some bony prominences and knuckles that are really at risk for irritation, blistering, or even, you know, ulceration. And that can lead to wounds and infections and amputations. So we try not to moisturize in between the toes because there's not a lot of air circulation if your toes are kind of stiff, or just in general, there's not a lot of air circulation in there. So we don't like to add too much moisture to an area that's already kind of trapping moisture there, because you have kind of skin on skin, which tends to trap the moisture there. So always drying in between the toes and checking and inspecting in between the toes is very important. A lot of people can't reach down there. I say, hey, you know, go to the local car store, you know, the AutoZone or the shop like that, and they sell these little mirrors that are on an extendable little pen, and, you know, or you can try to, on Amazon, sometimes you can get those mirrors that they have at the shoe stores. And so this way you can sort of inspect your foot if you don't have somebody to do it for you, and you can see the parts that you can't really reach down and look at yourself a little bit better. And so those moisturizers, though, can really help to nourish the skin and make it a lot less vulnerable to blistering and irritation and compromise, because once the skin is compromised, that's when we can see wounds or infections develop. So daily moisturizing, and, you know, the thicker the better. Vaseline, I'd say, is probably the best, but it's kind of messy and can get a little bit slippery. So, you know, Eucerin or CeraVe or anything that's real nice and thick, that's not going to just kind of rub in and evaporate quickly, those seem to be the best.
And we had our US Vascular Surgeon of the Year, Jacqueline Majors, who came on, and she actually told everyone in her interview to buy a mirror at the dollar store and put it in front of the toilet. And while you're sitting on the toilet, go
I
ahead
love
and
it.
check your feet. It's
I
Amen.
a
love it.
Yeah,
good way, it keeps you busy, right?
I'm going to
Well,
borrow that
Molly,
one.
yeah, I mean, it's great. She was very serious. It was full straight face when she said it too. We do have a question coming in from YouTube. I want to remind everyone, if you are watching on YouTube, that you can go ahead and put your questions in the comment section, and our YouTube producer Joshua will go ahead and bring them to our attention. So I want to get to this first one that we got from YouTube. It is from Tom Nowetner. Over the last 12 years, his legs have been getting more numb. His left leg is a little bit more than the right. It started since his aortic dissection and stenting. How does he proceed to restore blood flow? I'm guessing that he needs to get a CT angiogram of his legs to see if there's any narrowing going, down any further towards his toes.
Yeah, so generally with an aortic dissection, you can have compromised blood flow. I suspect if you've had an aortic dissection, you probably had a CT. Again, the comment I made before is true, that there's a lot of different causes of leg numbness. Is it possible that you have decreased blood flow there? Yeah, of course. Is it possible you also have neuropathy or spinal stenosis or something else going on? So the bottom line is, I think it's worthwhile getting that checked out. The place I would
Yeah.
start, which is the easiest place, is go back to your doctor who treated your dissection. If you were treated with surgery or interventional, go back to that person. If you were treated with just medical management, go back to that person and have them, have someone feel your pulses, take a look at your legs, make sure everything looks okay. I think the overlying message, and this kind of dovetails with the last speaker, which is you don't have to do this alone. If you have any questions, go to your doctor, go to your provider who sort of treated you and say, hey, my legs are numb. Do you think there's anything to do with that dissection you diagnosed me with 2 years ago, 5 years, 20 years ago? I think that's a good place to start.
And he's adding that he uses manual compression to aid in blood circulation. Is that we were always told that if you do have PAD,
Mhm.
that you do need to make sure, because certain levels of compression are contraindicated for PAD. So it's really good to make sure what your arterial flow looks like before you start a compression regimen. But what are
Yeah, I
your
think
thoughts?
yeah, I think that's spot on. I am always hesitant about people treating things without a diagnosis. And so, could you be doing something to improve your circulation in the setting of bad circulation? Yeah, maybe. But what if it's not bad circulation? Or what if you're doing the wrong thing to treat your circulation? And so, I'm all for Google and I'm all for WebMD and all these things. But don't forget, your doctors work for you. Okay, we work for you. Like, we're here for you. And so please have a low threshold to run it by someone and say, am I doing the right thing? Is this the diagnosis? What's going on? None of this is, you don't need to do any of this alone.
That's pretty amazing. You're going to make everyone sitting here expect more from their doctors now. Not every doctor says, come on down, come on down. Anytime you have some problem, just come on down.
No, I mean, look, the truth
Pretty
is,
amazing.
the healthcare system in America is overworked. There's no question. And there are times where I have patients who have 25 different complaints and they've got issues, and I want to hear them all. We may not have time, but it's a dialogue, right? Tell me what's most important to you, and we'll address that. And then we'll address the other thing next time. But it's your body, you're the boss, right? Like, no one knows your body better than you. And so
Yeah.
you sort of go in with a little bit of authority and say, look, here are the things that bother me. I cannot talk about 8 different things. I can't. But tell me the 2 things that are most important to you. And then have that dialogue. And that dialogue develops a relationship that I think is really important.
And we have Marie. Marie, do you want to go ahead and unmute and ask your question, or would you like me to jump in? She is asking, why do they recommend a podiatrist with PAD patients? She's never had an issue. She puts on her lotion, twice a day. She does her feet. She, cuts her toenails, and such. But also, why do they say it's not safe for someone with PAD to cut their own toenails, and that they should see a podiatrist to do that instead?
Yeah, I think that's an excellent question. And so for most people with peripheral vascular disease, there is going to be a real difficult time healing any sort of wound. The further we get away from the heart in the body, the less, the smaller the blood vessels are and the less blood is getting there.
Mhm.
And so by the time we get to the toes, there's just not a lot of blood getting there. The arteries that go into the toes are literally measured in millimeters, because they're so small. And so any little nick or cut or abrasion, if you happen, to suffer from one, a lot of people can't reach their toes the best as we get to an age where, Medicare is our primary insurer. We're over 65. Even if we're not over 65, if you have any sort of mobility issues or flexibility issues, it can be tough to reach and maneuver a nail clipper down there. Also, unfortunately, the nail clippers that everyone has at home are usually not sterilized. They're not as clean as they could be. And bacteria love metal. And so they will contaminate that metal. And if you do end up, sort of cutting the skin along with the nail, you can spread that bacteria to what might be just a tiny little cut, but that can then, unfortunately, you can have a problem healing that, and that can get infected a lot easier when you have peripheral vascular disease, and that can then lead to an amputation, unfortunately. So we
Yeah.
like to avoid that, and most insurance companies, if you have peripheral vascular disease, will cover or pay for a podiatrist or a dermatologist or a primary care doctor, any sort of doctor or provider, to cut your toenails and perform an at-risk foot exam. I think it's every 60 or 61 or 62 days. So that's usually, enough for most people, because as we get a little bit older or we have peripheral vascular disease, our toenails don't tend to grow as quickly, but they also unfortunately tend to suffer from fungal issues, which can cause them to get a lot thicker and just make them a lot tougher to cut. So usually your provider will have instruments that are sterilized and clean, and then they have just a better vantage point. They're closer to the area, and they're able to do it with a lot more ease than people at home.
Since we have you both here, we have both the vascular specialist and the podiatrist here. I think this is a good opportunity to really drive home the importance of lowering that A1C and taking it incredibly seriously. We have so many patients that are even pre-diabetic that we have to explain even one sugar molecule can end up wreaking havoc on your arteries. And so I want to hear from each of you, from your perspective in your practice, why lowering the A1C is incredibly important. Bring it down to even what the thickness of the blood, the stickiness of the blood, the syrupiness of the blood, whatever it might be. Let's really get to the heart of it right now to drive home this point. And I can see Dr. Lessne is ready to jump right in on this one.
Yeah, I mean, I've given talks to endocrinologists about this at the sort of biochemical level. And just to sort of lay it out, think about all the worst possibilities that could happen in your arteries. Like what would make it really bad? So, if your blood were stickier and it clotted more and sort of plugged it up more, if all that hardening of the arteries, sort of atheromatous disease, if that became less stable and it was more likely to shower, all these things happen with diabetes. Basically, everything you could think about that, how do I make this disease worse, happens with diabetes. And that's just in the arteries, aside from everywhere else in your body. And so, this is a tough disease to treat. For those of us who have dedicated our careers to treating this disease, in general, it's because we wanted a challenge. These are challenging, my patients go through a lot and my heart goes out to them. So every little extra step that we can take away, every extra challenge we can take away is only beneficial. So if we have a patient whose diabetes is out of control, if we can get that under control, that's one additional awfulness we can get rid of. If we have a patient who's a smoker and we can work together to try to get smoking cessation and stop smoking. That's one extra awfulness that my patient has to deal with. And so diabetes is the big one, no question. Smoking, kidney disease. That's for us the big three that really make this a challenging case. And so again, working with your primary doctor, working with your cardiologist, endocrinologist, to really get your diabetes under control is absolutely paramount.
Yeah,
I can't
we tell
remember if
our
we,
patients
yeah,
that before you go into any procedure, and I know, you know, I hate to tell you to delay any procedure, and I will never say if you have a wound that won't heal,
yeah.
we'll never say delay. But if you can delay a procedure at all and get that A1C under control, that's really, really paramount to durability, and long-term patency for that particular procedure and maintaining those vessels open, correct?
Yeah, and I would actually say it starts with education, right? Like I would say most of my patients, you ask them what their A1C is, and they say, I don't know. And so the first step is, what's your A1C? Because is it good? Is it bad? Is it okay? Is it somewhere in the middle? And so that knowledge is power. I'm a big believer in that. I think you
Mhm.
should know your cholesterol. I think you should know your A1C. Those are numbers that I think you should know. And if you don't know them, ask your doctor. And you will be surprised how often maybe you bring something to your provider's attention and they look and they're like, let me see. Well, you know what? Your A1C is a little bit high. Thanks for asking. We probably need to switch up some medicines. And so be your own advocate. And knowledge is the first step.
Yeah. And all the way down into the foot, Dr. Ellenbogen, those
Yeah,
small
yeah.
capillaries, they don't do so well with that extra sugar in the blood.
No, for sure. That's something that I preach daily to all of my patients is glucose control. There's a plethora of scientific evidence that an A1C above 7.0 will significantly raise your risk for postoperative complications should you need to have any sort of procedure on your lower extremities. So we know that just in, the general population. But for people who have been diabetic for, at least 10 years, they tend to suffer from more of the complications. And so we know that getting better control over your glucose and especially your A1C, which is a 3-month sort of long-term measure of your blood sugar. We can do a finger stick, we can, wear the monitor on our arms, and we can have a daily idea of our blood sugar and check it in the morning and, compare that. But the A1C doesn't lie. I mean, it's really a truth teller, and it's going to tell us what your blood sugar is doing over a 3-month period. And so, when your blood sugar is under control, almost literally everything in your body works better and functions better, from top to bottom. I mean, your cardiovascular, your musculoskeletal, your neurovascular, it's literally everything will work better. And we see patients with neuropathy that can sort of subside, or the symptoms can significantly lessen and be improve their quality of life. They heal better. They don't suffer as many complications from the diabetes when their blood sugar is better controlled. And I don't think, unfortunately, the general public is educated enough about that. I wish there was a way that we could do that more, but it's certainly something that once you enter the door to my office, we're going to talk about. And it's not a taboo topic, and it's not it's usually not the patient's fault. It's something that some people just don't know enough about. And so we try to educate them. I try to encourage them to read about it on the internet, or just ask questions, and certainly talk to their primary care doctor and endocrinologist about it as well. But certainly 100%, it will affect your feet. If your blood sugar is poorly controlled, it will have a negative impact on any of these conditions that we've been talking about tonight.
So we always talk about walking being the best medicine for peripheral artery disease because your body has this amazing network of collateral vessels that when you're walking and your body needs more blood flow, they dilate. And we always explain it as growing like tree roots. They can grow like tree roots around the blockages and reattach below the blockages. But we hear a lot from our patients who are diabetic, out of control diabetic, that they still struggle even though they're really trying to walk, walk, walk. And I'm wondering, and I was just thinking about it right now, and I could be wrong, but because the extra sugar in the blood can make it very thick and syrupy, since these collateral vessels are a lot smaller, I would imagine that they would have a little bit more trouble rerouting that thick, syrupy blood through those smaller vessels.
Yeah, so actually what happens is a sort of a cascade of things. So when you have diabetes, you actually increase the fat, you increase some hormones in your bloodstream. And one of those hormones that actually sort of downstream causes decreased ability to dilate your arteries. And so when you walk, think about those small arteries you just mentioned, Kim. When I'm walking, my legs say, oh my goodness, I need more blood flow. Okay, my arteries say, okay, no problem. I'll just dilate. I'll get bigger and turn into a 5-lane highway. Well, when you're diabetic, when your sugars are high, that impairs dilation. Your arteries can't dilate as well, even the small arteries. It increases the amount of fat that builds up into your arteries, which then cause your 4-lane highway to become a 3-lane highway and 2-lane highway. It decreases sort of how well those plaques stay in place, like I mentioned, and it increases the stickiness of your blood. And so, absolutely, I have patients who, I recommend a walking program and we talk about supervised exercise, but no matter what they do, it may not help their symptoms. Usually it's multifactorial. It's not just because of the diabetes, it's some other things going on. And so I think a very patient-centric approach, because I have patients who that does work for and who say, I don't need you to, for patients, I'm not talking about patients who are going to lose their legs. I'm talking about patients who just have claudication, sort of these pain. I do everything I can not to perform a procedure or operate on them because a lot of those patients do quite well with some conservative management, and walking is part of that. But you're absolutely right. If your A1C is 10 and you're a smoker and your BMI is 40, we're going to have a harder time. And so we need to concentrate on those things probably more than I need to concentrate on your arteries.
Yeah, a lot more. Thank you for explaining that really well too.
Yeah.
I don't know how much time you have. I've been monopolizing some of this time here. I want to get to some of these questions from our patients. And if you end up needing to cut short, just let me know. But I want to go to Grammy's phone. Nancy, go ahead and unmute and ask the doctors your questions.
This is for Dr. Lessne. Dr. Lessne, I'm in the clinical trial with Eli Lilly for the new drug lepodisiran. I'm not sure I'm pronouncing that right. I got my first injection 2 weeks ago. Had blood work done for my PCM last Friday, and my LDL went down 24 points. So I'm thinking I'm not getting the placebo, hopefully. Can you tell me what you know about that, and why aren't more people being tested for this? Because, it's like answering so many questions for me. My entire family has died early deaths. My grandchildren who are athletic now have high LDL, both of my sons. So I'm just into it because I'm learning, and Kim got me going down this path because she said, Nancy, you need to get an advanced lipid panel. There's something going on here. So that kind of started me on the journey.
Yeah, so I can't talk specifically about that drug, but I can talk about LDL in general and why that affects it. So, in all of us as we get older, a lot of times our cholesterol goes up. The situation you're describing sounds a little bit different. There are some people who all of a sudden you talk to them about their family and they're like, yeah, my cousin had high cholesterol in their 30s, and my uncle had a heart attack when he was 40, and my dad had a heart attack when he was 41. That's different, okay? And so there are patients who have genetic predisposition to having high cholesterol, high LDL. And the problem is, we talk about good cholesterol, bad cholesterol. So LDL is that so-called bad cholesterol. HDL is the good cholesterol. And what we know is that cholesterol goes up, it increases your risk of heart attack, stroke, atherosclerosis. And so if you have peripheral artery disease, we actually have reached the point where it almost doesn't matter what your numbers are. Most patients would benefit from some sort of therapy, usually statin therapy for this LDL, in the setting of peripheral artery disease. And what we talk about is this so-called high-intensity statin therapy. And so patients who've got peripheral artery disease, coronary artery disease, we often try to get them on high-intensity statin therapy if they can tolerate it, okay? Now, the situation you're talking about is, what if you don't have peripheral artery disease? What if you're otherwise healthy, but you have a strong family history? Well, that's where I think what Kim is saying makes a lot of sense. If you have a family history that's suspicious that something more is going on than just that, oh yeah, my uncle turned 80 and he has high cholesterol. Okay, well, so does everyone. If it's my, my young athletic sibling has it, then I think it is worthwhile to talk to a specialist, either a vascular specialist or your primary doctor, or even endocrinologist can walk you through this. They're often the first step, and they're very knowledgeable. And sometimes advanced testing is necessary because it may lead to more advanced or aggressive medical therapy.
Yeah, I've got it all. I've got 25-year diabetic, heart attack, PAD. I got it all. And so I'm fighting, and I'm trying to figure this out and doing everything I can.
Well, so that second part is key, right? Like, you just described that history, but then you ended with, but I'm my own advocate and I'm on the right thing and I'm doing everything I can, and no one can ask more of you. I mean, you are in control, and that is the key move.
Yeah. Okay. And we hear all the time that people are asking about the LP little a. And so it's really nice that we're seeing a lot more being done and I think a lot of doctors don't even look at LP little a because what are you going to do about it? So, I mean, other than what they normally have. But if these new drugs do prove to actually work, then that could be something that probably would be in their regular armamentarium when assessing patients. Marcia, go ahead and unmute and ask the doctors your question.
Thank you. First, I wanted to say, Dr. Is it Lessne? Is that how you say it?
Lessne? Yes, ma'am.
Yeah, wonderful voice you have. I want to hear you sing.
Thank you.
Me too.
Yeah, do that in the office. Yeah.
Yeah.
And my question is for you, Dr. Ellenbogen. I have PAD and want to find a podiatrist that specializes or is highly knowledgeable about PAD. And I was given a list by another podiatrist, and it basically was a society, like through the Podiatrist of America or whatever your associations are. And it was general. And there were, I go to websites of the different doctors, and they don't say that they specialize in diabetic care or elderly care or, vascular issues. So I'm wondering, and I still don't have one after 2 years. And I'm wondering, how does a PAD patient filter out and find, just like bad vascular doctors or cardiologists, filter out the bad podiatrist?
Dr. Ellenbogen, I have the same question.
It's an excellent question. And so unfortunately, it's probably something that would take a little bit of fact finding and digging. But usually if there is a podiatrist who focuses on that, the local primary care docs will know about it. The vascular specialists will know about them. And so those are some places to ask or look. There is something called the American Limb Preservation Society, ALPS, that is newer, within the last couple of years, but they are, it was started by a mix of a group of vascular surgeon, podiatrists, et cetera. So, there is a list on sites like that of providers, whether or not someone is local to you. You could probably find out by looking that up.
Here's what I wish, though,
is
I wish, and Dr. Lessne will probably back me up on this one. I think the Society for Interventional Radiology has literally the best doctor finder because it breaks it down for you. The problem that I find in all these lists is we need to make sure we find the actual specific peripheral artery disease, vascular, diabetic foot specialist. Like, you go to sirweb.org for interventional radiologists, if someone specializes in peripheral vascular disease, or if they're specialized in genicular arterial embolization, or, fibroids or something. But we got to have that. We need even the APMA to get on that and create that list.
I
and
agree,
disseminate
100%.
Between a sports doctor.
I think that podiatry is already sort of a specialty, and so it has evolved and matured over the last 3, 4 decades to sort of subspecialty areas.
Yeah.
But we need to do better at publicizing that. So I think if if you look at the APMA or your state society, there will be, whatever state you're in, there will be a state podiatry association most likely, and you can probably reach out to them, and whoever runs that will probably or hopefully be able to point you in the right direction for someone who could help you in that area. But I will say, even a podiatrist specializing in sports medicine is going to be able to perform, a cursory exam and be able to evaluate you for peripheral vascular disease, and then likely be able to refer you, if needed, to someone who could help you.
Yeah, and Marcia, if you go to padtest.org, we actually have a list of, and I just thought about this just now because we haven't really advertised it, but we partnered with Biomedics, and Biomedics has the PadNet, the testing device for PAD, and it lists all the podiatrists and primary care physicians across the US. There are more than 1,000 of them. They're not in every area yet, but it has all the ones that actually have that PAD test. And so I would imagine that if one of the doctors listed
Absolutely.
on that website has that PadNet, the pad testing device, I would think that they would be one that would have a little bit more information about PAD than maybe some of the other ones that might not be on the list.
Absolutely. I agree with you, Kim. That's a great recommendation. I have a system in my office that does the same thing as the PadNet, which is PADNET. That's a machine that performs a peripheral vascular disease test in the office that a fair amount of podiatrists have. I have one called the Smart ABI, and so they have a website as well that you can, and they'll probably have a provider directory of what podiatrists or other specialists have their machine. So
Yep.
Either of those two websites are probably going to have some resource for you.
What was that? Smart what?
Smart ABI.
API. Okay. Yeah.
And
Yeah,
Marcia,
between the two of them.
yeah, I was going to say, I wasn't being facetious when I said I had the same question. We struggle too. I am absolutely blessed that I have Dr. Ellenbogen and some of his colleagues that I work with. But there's no question that, not everyone's created equal. And I guarantee you, he's got the exact same story, that he's got some vascular specialists he works with or tried to work with, and they say, whatever, whatever it is. And so just realize that providers and doctors struggle with this too. I think the best resource is what they've mentioned, websites, and also ask your friends, ask your primary doctor, ask your primary provider, who would you recommend? And the other thing is, again, if you go to someone, you're like, this ain't working, switch. We work for you. Okay. I won't be insulted.
Marcia, we do have Dr. David Alper, who's a board of trustee for the APMA, and he's in our group, and you can tag him anytime. And he has said that if you want the best podiatrist for PAD, he will seek them out for you.
Awesome.
I did ask him, and I haven't seen follow through, but maybe that's up to me to follow.
We'll get him.
Tim's on it.
Easy, kind tag in the
Right.
group to say, I'm waiting.
Can I
And
ask
I'm
one?
sure he'll do it.
Marcia, if you'd like to leave your information with Kim and she forwards it to me, I can help you try to find somebody locally.
I would
I'd be
love
happy to
that.
Take a few minutes and do that.
I would love it.
Sure.
Thank you.
Yep.
Real quick follow up. You were talking about Vaseline on the feet, which I do find really greasy. How do you feel about baby oil?
Yeah, I saw your comment there. I mean, baby oil to me is almost greasier than Vaseline. I find that baby oil is probably better to remove makeup. I just know that from my 9-year-old daughter who dances and, has to put on tons of makeup. Because it's a little bit thinner, it doesn't create that sort of hydrophobic seal that we're looking for. It doesn't trap in the moisture to the skin for as long or as well as Vaseline will. So, while it's great for sort of decreasing friction and on the skin and avoiding blistering, it just tends to get absorbed and evaporate a lot quicker than something a little bit thicker.
Perfect. Thank you. I'm
Good
sorry.
question.
Do you both have a few more minutes here? Or are you in a rush to jet off and go save some piggies?
Go ahead. We can answer. I can answer a couple
Okay.
of questions.
We do have, Marie had another question, which I overlooked here. It was about drop foot. And the reason I think this is really important because I had a chance to visit another patient today at a rehab facility. Her name is Diana, and Marie knows her. And both of them have experienced drop foot following procedures. Can you talk about what might be the issue there? What might have caused them? Is it circulation related? I don't know that much about drop foot, so I'd be curious your experience with that and what causes it.
Drop foot is, it's a very difficult condition to deal with. And it can be transient and it can resolve, or it can be permanent. And it can happen for a few different reasons, but a lot of, sometimes even just giving birth can cause drop foot. But usually that will resolve. And literally it happens when your certain nerves are not sending a signal to the muscles that help you to lift your foot when you're walking. And so the question is for, anyone with a drop foot of unknown cause is, why are those nerves not getting the signal that they should be anymore? Is there a permanent injury to the nerve, or is there just sort of a bruise or a temporary injury that the nerve can recover from? So the most important thing is to probably find out why that nerve is not working, and if that nerve is sort of dead, or if it's just maybe asleep. And that can usually be done with a couple of different tests, but the most common is what's called an EMG NCV, an electromyogram nerve conduction velocity study. That is not the most fun study to have, but it only takes about 30 or 40 minutes to do, and it can provide, incredibly helpful information. And it's usually done by a neurologist, and your primary care doctor can probably refer you off for that. Day to day, there are a myriad number of shoe adjustments and braces that either a podiatrist or an orthotist can help make you, that can either be off the shelf or custom made, that will help you walk a little bit better, improve your balance, improve your gait, and help avoid trips and falls, which is most important. And then, just kind of making sure that you are paying attention to your surroundings, trying to avoid uneven surfaces as best you can, and really being careful with curbs and stairs and all that stuff. And keeping sort of a, I always tell patients, just a well-lit path to the bathroom at night.
Yeah, I just want to echo this sentiment here that, even nerve damage that's not permanent can take months to resolve. So it's not an overnight thing necessarily. And so all these issues, including, moisturizing your foot and foot drop, you want to make sure that while you're not making things worse. In other words, a fall can be devastating to an elderly patient or a patient with comorbid conditions. And so even if you have a foot drop that says, oh, it's going to get better, you need to make sure you're right with the right foot. You need to make sure when you walk, there's about, Dave probably knows better than I do, 1,000 different things that happen without you knowing it to make sure your foot has little micro adjustments. And you lose a lot of that, not only with foot drop, certainly, but you lose that with diabetes, you lose that with neuropathy. And so it's very easy to be a little bit more clumsy than you think you are. And a fall can be devastating. So, things like lotioning your feet, that's great. But please make sure your feet aren't slippery and you're going to fall. With foot drop, please make sure you see your podiatrist and make sure you get the appropriate shoe to make sure you're not setting yourself up for a disaster.
Okay, we have 3 more questions just from our studio audience, and I'll get to my final ones. Okay. And then we'll let you get on with your evening. We appreciate you so much for devoting so much time, and we have so many people that are really enjoying this conversation and appreciating your time and respect for those questions that they have. I want to get to a YouTube question. We also have Dee who has a question, and Brenda who has a question. So get ready Dee and Brenda to unmute in a moment, but I want to get to the YouTube question. What's Up Solar said the latest ABI was 0.6 and they walk 10,000 steps daily, but the pain is very hard to bear. Is there any hope of that pain becoming less?
So the answer to the question is yes, there is hope. 0.6 ABI is not what we consider a normal ABI. So an ABI is basically how much blood pressure you have in your ankle. And obviously, if you have restricted blood flow, that pressure is going to drop. So you do have evidence of peripheral artery disease. And if you're getting pain when you walk, that is a sign that you have symptomatic peripheral artery disease. So there's some peripheral artery disease that, has no symptoms. You just have some narrowing. You'll never know it. It sounds like you have some symptoms. The question is what to do about it.
Yep.
If you're walking 10,000 steps and you're living your life, you don't necessarily need a surgery or a procedure. What you may need is, number one, cardiovascular risk reduction, right? You want to make sure that you're not at risk for having a heart attack and stroke, or that risk is lowered. Two, you may need a walking program. It sounds like you're kind of already doing it. Three, there are some medicines that have been shown to increase pain-free walking distance. And so these are things you need to talk to your primary doctor about or your vascular specialist about. But the answer to your question is yes, there are ways to treat you. Yes, you can feel better. It sounds like you're doing a lot by yourself, which is awesome. Now just get yourself a little team and you'll probably be even better.
The one thing that is interesting, we do get a lot of people that say, I walk this many steps per day.
Mhm.
But what's really important, it's not how many steps per day, because that can mean anything.
Mhm.
They could have a wide stride, they could have a short stride,
Yep.
whatever. What really matters, isn't it, that 30 minutes that they do spend in a regimented time frame, focusing on that walking and pushing through that pain?
Yeah, so the walking program that we recommend is, in fact, the only walking program that's really been shown through the literature to make a difference is what's called a supervised exercise program, where you go to physical therapy, someone walks you and watches you. A lot of patients can't do that for time restraints or insurance restraints. And so what we do recommend is 30 minutes a day. And the idea is you walk until you get that discomfort and then pause. Don't torture yourself. Pause, relax, make sure it goes away, and then walk again. The catch is when you walk, when you're pausing, that doesn't count towards your 30 minutes, okay? So if you walk for 10 minutes and then you have to pause for 5, you've done 10 minutes of your 30-minute walking program, okay? But I would say that the more important question, and this is the question I ask every single one of my patients, is, tell me how this affects your life. Because there are patients who can't walk, 10 feet. But they're like, it doesn't matter. I have someone do shopping for me. I just walk back and forth to the bathroom and I'm limited by my breathing. I have bad COPD, whatever it is. Okay, so that person may not need treatment because their quality of life is not affected by their legs. And so it's not so much how much you walk, it's how it affects you. Okay. Whereas I've treated mail workers, like post office workers, who literally say, I can't do my job. Well, that's a very different disease, right? That's a very different way of approaching it than someone who's like, I'm a couch potato, I never walk, versus I walk all the time for my job and I can't do it. And so really patient-centric, sort of what about you makes this disease hard, I think is more important.
And we have 2 more questions here. We have Dee, and then we'll get to Brenda. Dee, go ahead and ask your question. We are not hearing Dee, so I am going to go to Brenda. Brenda, go ahead and unmute and ask the doctors your question.
Hi.
Hi, Brenda. Good to see you.
Nice to see you, doctors. Have you known of anybody complaining about what xylazotol? Am I pronouncing that right?
Yeah,
the pill
xylazotol.
that. Have you known of anybody to complain about it causing bleeding,
Yeah,
like the other blood thinners?
Yeah, so cilostazol is a medicine we use pretty commonly in PAD. It can cause some increased. It's usually not as bad as an anticoagulation. In other words, like a Coumadin or a warfarin or a Lovenox, a true blood thinner. But it certainly can have some side effects. That said, you can decrease the dose. And so, usually cilostazol will start a certain dose. And if patients can't tolerate for whatever reason, GI upset, bleeding, whatever, we can decrease the dose.
Yeah.
And so that is a first conversation to have with your doctor. If you're like, nothing's changed except for this medicine and I'm bleeding more, you probably need to start with, and they either stop it or they'll reduce the dose.
Okay. Thank
And
you.
so,
Yeah, it's a good question.
Cilostazol, Brenda, the last study that I read said that it works in 30% of individuals. And when it works, it really, really works. But if it doesn't work, the side effects kind of suck. So it's definitely something to have a discussion with your doctor about if you do think that there's any sort of side effects to, with it.
Yeah. And it's part of our sort of conservative management. So in other words, patients that are not ready for surgery or inappropriate for procedures, we'll start them with cilostazol, walking program, diabetes management, things like that. And so it can be effective, but yeah, like any medicine or like anything, it can have side effects.
And you know what, we just had a functional medicine practitioner / nurse practitioner on last week that gave me new information on ginger, which I had no idea. I didn't know that ginger is a vasodilator. Had no idea. So I thought that was kind of interesting. So it might be something that you can also talk to your dietitian or nutritionist about to see if there are also natural ways in which you can supplement or eat some additional nutritious foods that might help you improve your walking distance. You never know.
And dark chocolate.
Dark chocolate. Thank you, Brenda. And I do have the question from Dee. So Dee wants to know from Dr. Ellenbogen, is there anything that she can do to improve edema in her foot and also clawed toes on her foot that is most affected by her PAD?
That's a great question, and something so many people have to deal with on a daily basis. Edema in the lower extremities is extremely common and can be tough to figure out what it's coming from because so many things can cause edema and swelling in the lower extremities, from gravity, age, number of children you may have had for women, genetics, just a family history of poor circulation. A lot of times the veins, which are the blood vessels that carry, the blood back up to the heart, can be complicit in causing swelling in the lower extremities. And then people who tend to work on their feet a lot, some people who have had injuries in the past, broken an ankle or something like that, can suffer with long-term edema. And so it's important to kind of figure out why and rule out the dangerous things. And then you can kind of figure out a treatment from there. A lot of times the first line treatment is some sort of elevation and or compression. And a lot of people who find that, as long as the edema is in both of your legs, then usually it's from something pretty simple to figure out. But if it's on only one side, then sometimes it can be a little more dangerous. So it's important to kind of pay attention to that. So it's something that should be looked at by either a podiatrist, a vascular specialist, a primary care doctor, and sort of go through the steps to figure out what's causing it. And then you can kind of start with, usually I start with the simple approach, but it's important before you start just treating it yourself to get it looked into, because sometimes if you have some other things going on and you just sort of start to treat it on your own, you can make some other things worse. So it can be a sign of nothing, or it can be a sign of something. So it should be evaluated by a professional.
Thank you. And Marcia's going to jump through her screen if I do not let her jump in one more time and ask a question. We love you, Marcia. We appreciate you. Always some great questions. So just really quickly, it's for Dr. Lessne.
Yes. You were talking about cilostazol.
Cilostazol?
Sorry. Yes. And my question is, by your response, I guess I want to clarify or make sure that I understand your response. I was on it. And I hated it. I bruised all the time. I bled all the time. I felt like I, was an old person. It reminded me of my grandfather when I was little. And I just hated it. So I changed my lifestyle, quit smoking, got active, lowered my cholesterol, and I said, I want off of it. He said, wait 3 months at post surgery. And he took me off of it. I'm not at risk.
Can I ask you, are you talking about cilostazol or clopidogrel?
Oh, I'm sorry.
Yeah.
Clopidogrel.
Yeah, clopidogrel.
Yes.
Yeah.
Yes.
So
Or Plavix.
clopidogrel is Plavix, which is like super aspirin. And exactly what you said is correct. It can cause bruising. It can cause all these things. Unlike cilostazol, where I tell my patients, we'll try it. If it doesn't work, we'll stop. You have to give it a couple months, but there are some patients who really need clopidogrel or some equivalent. For example, if you've had a stent, especially a stent in your heart, a stent in your legs, depending on the type of stent, we often want aspirin and clopidogrel. Now, if you can't tolerate it, that's okay. There are some other things we can do, but that's definitely one of those medicines where you don't want to stop on your own. You want to talk to your vascular specialist, and I suspect why he or she may have told you, please wait 3 months. But yeah, there are some patients we don't want to take it off right away, or if we do take it off, we got to figure out another strategy.
Because I'm not on anything. Well, I'm on medicines, but not that. A baby aspirin. That's it.
Yeah. Yeah. So, again, I think that's a conversation for your individual risk profile. There are some studies that show that additional medicine in addition to aspirin may lower your risk of major cardiovascular adverse effects. But that's going to be tailored to you. But that is absolutely a conversation you should have with your primary and say, do I need to be on anything else? What are the risks? What are the benefits? I think that's a good conversation to have. Yeah.
Okay, our final three. I promise this is the end of the road here. But these are everyone kind of stays, we have our amazing contingency of folks, Marcia and Brenda and Nancy and Hines and Alan and Josh even who love staying to the end for these three questions. So really excited about these. Journey to diagnosis. So talk about a case. We love a specific case that ends up being representative of a trend out there. So of someone that came to your office and you just shook your head and you said, oh my God, I cannot believe that this person was not diagnosed with PADS sooner. How is this possible? And we'll start with Dr. Lessne first, and then we'll give Dr. Ellenbogen just a moment to think about that.
I'm going to cheat, and I'm going to alter the question a little bit.
Uh-oh.
And let me tell you why. I have patients come to my office, and they're diagnosed with PAD. But what I shake my head about is that they have been to vascular specialist after vascular specialist who said, you've got something going on with your legs. There's nothing we're going to do. This wound is getting worse. You're probably going to get an amputation. And they go to another specialist and it says, yeah, there's nothing we're going to be able to do. Your advanced disease it's too advanced. Your PAD is too advanced, nothing to do. And they come to me and I say, maybe, but let's try. Let's at least try. And there are patients, I can show you case after case after case, where I have letters that say nothing to do, amputate, nothing to do, amputate. I can get I can revascularize them. In other words, I can get them, open up their blood vessels, get them blood flow all the way to their toes. I can send them to an expert like Dr. Ellenbogen to help me out with the orthopedic and foot and ankle surgery. And these patients heal. And maybe they lose a toe or a couple toes instead of the whole leg. And I shake my head every single time, because it's not that the patients did anything wrong. It's not that they didn't have someone who legitimately wasn't interested. I think those doctors were legitimately interested in helping them. There was just a lack of education or a lack of sometimes humility and saying, I can't help you, but maybe someone else can. And that's why I think what Kim does is unbelievable, because I can't do everything. But guess what? I bet you there's someone else. I bet you there's an endocrinologist who knows more about endocrinology than I do. Bet you there's a ophthalmologist that knows more about eyes than I do. And so I look for help. I have a very low threshold to ask for help. And so I appreciate people like Kim sort of organizing things like this to educate us doctors too.
We always say, don't give up on the patient, give up the patient. If they're on deck for amputation anyway, why not try? But still, so many doctors are afraid to give up the patient. Number one. Number two, there's still a lot of these doctors that are so nose to the grindstone in these smaller community hospitals and don't even come up for air. They don't know that there are options now available. They have been hiding under a rock in a sense, because they're so busy.
Yeah.
So many hospitals, I mean, the fatigue with physicians, it's a real thing. And
Yeah.
so not
It's not
everyone has the
malicious.
ability. Nope,
Absolutely. It's
it
not
really is.
malicious and it's not laziness. It really isn't. Most of these doctors want to go do a good job. They just don't know they don't know the things that I and Dr. Ellenbogen can do. And that's okay.
Now, I will say that there are a
Sometimes.
couple. Um, I will tell you why delay the inevitable. We're gonna have to chop off their leg anyway at some point. Why not today? I mean, you know, you're just delaying the inevitable. And I know most patients will say, you know what? I would rather walk to live another day and live to walk another day than
Yeah.
to lose my limb right now. So that's the way we operate. We honor the patients, and I'm glad to hear that you give
Yeah.
it your best shot as well. Why not try? At
Yeah.
least try, right? And so that's really important. Okay, Dr. Ellenbogen, you're up.
Yeah, I think, the thing that comes to mind for me with this kind of scenario is patients that have come in and have recently had a total knee replacement or a total hip replacement, or they've had a carotid, procedure done. And then they come in, and the first thing that I do when I examine a patient, every patient, no matter why you're here in my office, is I check your pulses. There's two pulses in the foot and ankle that are easy to find in almost everybody, about 94% of the population. And so if I can feel those and they're really good and strong, then we're probably okay. But once in a while, I'll have a patient who's recently had a surgery on their lower extremity and they don't have a great pulse. It might be weak or it might be absent, but they've had surgery higher up in the leg. And so it just goes to show you that just because one thing is doing okay doesn't always mean that everything is doing okay. And so if you have symptoms, you should definitely get them checked out, no matter, what else you might have had looked at recently, because it is impossible for every doctor to evaluate you for everything. And so it's always good that's why it's great that we have specialists in this country, because, we usually have a focus on a certain area or system in the body. So thankfully, usually those patients can be referred to someone like Dr. Lessne for a quick intervention if needed.
And we always say to our patients a good rule of thumb before any major surgery, whether it's hip surgery, knee surgery, whatever it might be, especially if you're over 50, especially if you have risk factors for PAD, is make sure you do get your blood flow checked prior to any of those procedures, just to make sure that you are at the very least going to heal properly, right? Okay, two more questions. Thank you for your time. A case where you had an incredible learning. So bring me back to a specific case in which you learned a very critical lesson. It could have been a success, it could have been a failure, but it's a lesson that you learned that you still apply today, and others can learn as well.
I have one. If Dr. Lessne needs a second to think, I mean, this was sort of at the beginning of my career, probably a good 15 years ago, and it still sticks with me. And I still think about this woman all the time. And it definitely changed how I practice. But she wanted her bunion fixed. She had some arthritis in her foot and her big toe joint, and wanted it fixed. And she had pulses in her foot that were okay. They weren't terribly suspicious. So we went ahead and did that. But she did have a 30-year smoking history, but she had quit about 5 years prior to that. And so we went ahead and did the procedure to fix her bunion. And my goodness, she came in with the complete inability to heal her incision, and that formed a wound and an infection, and she required multiple surgeries to fix that and an intervention to improve her circulation. And so for me, it just reinforced the need to take everything into account, always take a thorough history, and don't be fooled by just what's in front of you. A lot of times you need to really evaluate the whole patient and their history, not just kind of what you can see right in front of your face.
Yeah, I love that. Very important lesson. Dr. Lessne?
Yeah, so this patient I think about a lot. I had a patient who came in very routine, came in with a wound, had peripheral artery disease. I went through everything with him. I said, good news. I don't think you need an open surgery. I think I can fix this minimally invasively. You'll come into the hospital. You should go home the same day. No, blah, blah. And under his breath, he kept going, damn. And I went through it again and I said, no, this is good. We're a team. We'll figure this out. We'll get this through. You don't need to be cut open. I can do this through a tiny hole. We can send you home the same day. Damn. And it took me probably longer than it should have. And then finally I said, what is going on? Like, I feel like we are in a good place. And I find out that he lives by himself. And he's really concerned about who is going to take care of his guinea pig. Because he has no family, he's got no friends, and he doesn't know how he can get to the hospital. And if he goes to the hospital, who's going to take care of his guinea pig? And God forbid he spends overnight. And that was eye-opening to me because, we think as doctors, we're so sophisticated, we have it all figured out, we can do all this specialized procedures and do all these things. But the bottom line is, if I can't help this guy take care of his guinea pig, I can't help him. And so that taught me a lesson that there's so much more than what I do. And I'm going to quote when I was in medical school, during my obstetrician gynecology rotation, okay, we had to rotate through that. My professor, who was a gynecologist, said, when someone comes into his office, the first thing he thinks about is, what does this person have if it was a man? So in other words, you have this person who only treats women. And the first thing he thinks of is, what happens if it's not a woman? And what I took away from that is, get out of your little pigeonhole, right? You live in this world, but patients don't live in your world. Patients live in their world. And so patients who come in to see me as a vascular specialist, they've got neuropathy, they've got stenosis, they've got something else going on that's not vascular. They've got guinea pigs. And so my world doesn't revolve around their world. And so that was a good learning lesson for me.
Yeah, that's so important. I see it every single day. And so that's something that we also help with, because the healthcare system doesn't provide the additional care that a lot of these patients need if they do live alone. And so many of our patients do live alone. And so what we do is we try to help as much as we can find the pet sitters for them. We also help with making sure that they do have someone that can check on them. We'll hire, one of those nursing services to just come in and check on them as well. And so
Amazing.
that's one of the things that's really important about the Global PAD Association is we are right there to try and help you do what you do and help, make sure you can give that timely, effective limb-saving care and remove all of those logistical barriers that might be preventing it. So yes, really, really important. Okay, final question. Your most defining moment in your career, the 6 minutes that matter. Was it a movie? Was it a moment in a movie? Was it a patient? Was it something you witnessed? Was it something your parents said to you, a sibling or partner said to you? What were those 6 minutes that matter that became a defining moment in your career?
I'll start this one. First of all, there's about 1,000 of them. Okay. If you do anything, you know that there's a lot of people who have sort of smacked you in the head and had a defining moment. But the one that comes to mind is I think a few years ago, I came home and I was complaining about something to my wife. And she said something about, I have to do all this extra work and, why am I doing this? And it seems like other people aren't, and I have to work extra. And she goes, stop doing it. And I said, but I don't want to. She said, why? I said, because I have to, like patients need me by. And she said, then shut up about it. And I'm like, that is a really good point. Like, I'm not going to stop doing it. And so it doesn't matter what other people do, just be true to myself. And so I'm going to do it because I think it's the right thing to do. And if I work harder than someone else, that's okay. Someone else is working harder than me, I guarantee you, right? And so just shut up about it. And she said it in a very loving way. But sometimes you need that. You need someone to be like, if you want to vent, vent. But if you want to change something, change it. If you don't want to change it, own it and move on. And I think that was a very good experience for me.
I love that. That's fantastic. That's
Yeah.
good for anyone.
Yeah.
Okay, Dr. Ellenbogen, you're up.
You know, after a long day, my my recall is not as sharp as it probably would be at other times. So, but one thing that does stand out is, you know, when we first entered the pandemic, here in Charlotte, and I'm sure in a lot of other places around the country, it was just really nice to see the recognition um, around town and in public for the healthcare workers, and not just doctors, you know, nurses, hospital staff, you know, the healthcare force that a lot of times gets taken for granted, or maybe not for granted, but just doesn't get the recognition that they deserve. A lot of times it's a thankless job, and most people don't go into it for the gratification and the thank yous, but it is nice to, you know, sort of see that. And I think it probably meant a lot to a lot more people than just me, but having that sort of, you know, connection within the community, to know that there's, you know, that even though we're on one side and patients are on another, it's not, you know, we're all just part of the same community. And you know, to sort of have that hero verbiage associated with healthcare providers was nice. You know, I don't let it get to my head or anything, but it was very nice to hear.
Yeah.
And I think it was a nice, it was just a time where everyone sort of felt like, well, yeah, we're all connected. You know, either the providers and the patients, you know, we're all here in this together. And I just kind of, that always stands out to me.
Wow, what a beautiful way to end this amazing conversation that we've had. I think that you guys have actually taken the record for the longest What's Up talk that we've had thus far,
Whoops.
which has been amazing. We would love to have you guys come back even on a regular basis. You guys are a lot of fun, very informative. We appreciate you so much. And for those of you that have joined us on YouTube, make sure to like, make sure to subscribe, make sure to get notified when we have these amazing Q&A sessions with doctors every Tuesday. But thank you so much, Dr. Mark Lessne and Dr. David Ellenbogen, both in Charlotte, North Carolina. We really appreciate all you do to save life and limb, and we really appreciate you taking the time out of your busy schedules after a very long day and after a big hurricane, to be here for us and to help so many patients across the globe. Thank you from the bottom of my heart.
And thank
Thank
you,
you.
Kim, likewise, for everything you do and everyone on this to take the time out. This is very meaningful. Thank you. And be safe with the next hurricane that unfortunately is coming. So please be
Yes.
careful, everyone.